Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, in Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about the different metabolic diseases. In the last lecture, we have discussed about the disorders of the sodium metabolism. In today's lecture, we are going to discuss about the disorders of the potassium metabolism. So I believe that you must all have gone through the book and you must all have prepared the notes of the sodium metabolism and also answered the questions that I have given on the portal. So let's start with the disorders of the potassium metabolism. Now, as we have discussed earlier, there will be a small recap of these fluids because this is a separate topic. Body fluids we are going to discuss about. So water contains around 60% of the body weight. So the content of the water is around 60% and the fat content contains less amount of water. So in the obese people, we have less body water and the water in the body is distributed in the two compartments. One, we have extracellular compartment and the other is the intracellular compartment. Intracellular compartment contains intracellular fluid that is 66% of the total body weight, total water content of the body, and extracellular fluid contains 34% of the total water content of the body. The extracellular fluid again consists of three parts, that is interstitial fluid, intravascular fluid, and transcellular fluid. The interstitial fluid is around 65% of the total extracellular fluid. Intravascular fluid is 25% of the extracellular fluid, and transcellular fluid is around 10% of the extracellular fluid. In the intravascular compartment, only 10% is in the arterial system, 55% remains in the capillary system, and 35% remains in the venous system. Now, the distribution of the body fluids. Intracellular fluid is around 40% of the body weight and extracellular fluid is 20% of the body weight. Out of this 20% of the body weight extracellular fluid, interstitial fluid is around 10% and 15% and the plasma is around 5% of the body weight. Now, coming to the differences between the extracellular fluid and the intracellular fluid. Extracellular fluid is present outside the cell, whereas intracellular fluid is present inside the cell. The protein content in the extracellular fluid is less as compared to the intracellular fluid protein content. That is more than the extracellular fluid. The major cation is sodium in the case of extracellular fluid, and it also contains potassium and calcium. Whereas in the intracellular fluid, the major cation is potassium. So we have discussed about the sodium metabolism in the previous lecture. Today we are going to discuss about potassium metabolism. The major anion is the chloride ion and in the extracellular fluid and phosphate in the intracellular fluid. Now, what is the requirement for the biochemistry? The biochemistry lab investigations are required for screening of the asymptomatic subject, number one. So we can screen the asymptomatic subject if they are coming to us to assist in the diagnosis of the patients presenting complaint. So we can either diagnose an asymptomatic patient or we can assist in the diagnosis of the patients presenting complaint. And biochemistry, it's a lab investigation is also required to monitor the changes to the test results. So we have to monitor the test results as a marker of disease progression or response to the treatment. Now we come to the potassium metabolism. Potassium metabolism is related with the metabolism of potassium in the body. As we have studied just now, that potassium is the major mineral in the or the major cation in the intracellular fluid. So excess or deficiency of this particular cation is responsible for development of multiple disease conditions. So as we have seen in the potassium sodium condition, potassium can also be more or it can be less. If it is more, it will be known as hyperkalemia, and if it is less, then it will be known as hypokalemia. So let's start with the potassium metabolism in the body. Potassium is the major intracellular cation, and it plays an important part in generating the resting membrane potential. So potassium is the major intracellular cation, and it is playing an important role in the generating the resting membrane potential of the body and allowing the propagation of action potential which is crucial to the normal functioning of the nerve, muscle, and the cardiac tissues. So we have potassium, that is the major intracellular cation, and it is playing an important part in generating the resting membrane potential. So potassium is responsible for maintaining the resting membrane potential, and it is allowing the propagation of the action potential. So generation of the action potential and which is responsible for the normal functioning of the nerve. So in absence of the potassium, the nerve conduction is defected, or in any sort, either if it is increasing or decreasing, and then the nerve conduction will be deranged. So that will lead to the muscle and cardiac tissues contraction. So aldosterone is the important factor in the acute and chronic adjustment of potassium secretion. So potassium is, as we have just studied, it is a major intracellular cation, and it plays an important role in generating the resting membrane potential and allowing the propagation of the action potential, which is crucial to the normal functioning of the nerve, muscles, and the cardiac tissues. Aldosterone is an important factor in the acute and chronic adjustment of the potassium secretion. The disorders of the potassium are categorized into two. One is hyperkalemia and the other is the hypokalemia. In the hyperkalemia, we have potassium excess. In the hypokalemia, we have potassium deficiency. The normal level of the potassium range is 3.3 to 4.7 millimole per liter. So the normal range of potassium in the body and the intracellular fluid, it is around 3.3 to 4.7 millimole per liter. If it is more than 4.7 millimole per liter, it is known as hyperkalemia, that is potassium excess. And if it is less than 3.3, then it is known as the potassium deficiency or the hypokalemia. Now let's discuss these conditions one by one. First of all, let us discuss about the hypokalemia. Hypokalemia means the decreased level of the potassium. So what are the different causes of hypokalemia? Hypokalemia is caused due to either decreased intake or excessive potassium loss. So either you are taking less potassium or there is more loss of the potassium. So what are the different ways by which there can be decreased intake or excessive loss? So there are various gastrointestinal causes. Gastrointestinal causes, which includes decreased dietary intake of potassium. There can be GI fluid loss, which includes prolonged vomiting and diarrhea. There can be fistula, mucus secreting adenomas, and uterosigmoid anastomosis and paralytic ileus. All these conditions belong to the GI system that can be responsible for the decreased level of potassium in the blood. There can be renal losses. Renal losses can be seen in the cases with diuretics. Diuretics includes thiazides, loop diuretic, and osmotic diuretic. It causes metabolic alkalosis. There can be excessive cortisol that is causing aldosteronism. Aldosteronism can be primary or the secondary. There can be Cushing's syndrome. There is renal tubular disorders with renal tubular acidosis, leukemias, antibiotics, and magnesium depletion. So we have renal losses, which includes the diuretics, thiazides, loop, osmotic. It causes metabolic alkalosis with excessive cortisol and causing aldosteronism, primary and secondary. It can cause Cushing's syndrome with renal tubular disorders, renal tubular acidosis, leukemia, antibiotics, and magnesium depletion. Due to the shift of the cells, hypokalemia can also be seen due to the shift of the cells, which includes hypokalemic period paralysis, alkalosis, and insulin effect. Now, what are the clinical features of hypokalemia? Whenever a patient of hypokalemia is coming to us, what are the clinical features with which the patient can present to us? The clinical features will include muscle weakness. So there will be muscle weakness because of the decreased action potential. There will be tetany. The patient will complain of fatigability. So if the patient is tired, if the patient is fatigued, if there is tetany, then you can think of potassium loss or the hypokalemic conditions. There will be thirst. Now, the patient will be having great thirst with polyuria. There will be paralytic ileus and cardiac arrhythmias that we are going to see. So there will be muscular weakness, tetany, fatigability, thirst, polyuria, paralytic ileus, and cardiac arrhythmias. Now, what are the various investigations that could be done in such cases? Management of the plasma electrolytes, bicarbonates, urine, potassium, and sometimes plasma calcium and magnesium can be done. So we can measure the plasma electrolytes, bicarbonates. urine potassium, and sometimes plasma calcium and magnesium. The plasma renin activity is low in the patients with primary hyperaldosteronism. The management of urine chloride concentration A with low urine chloride less than 30 millimole per liter, it is the characteristic of vomiting, while the urine chloride greater than 40 millimole per liter suggests a diuretic therapy. There are different ECG changes, which includes ST segment depression and appearance of the U wave. And severe hypokalemia, it produces premature ventricular or atrial contractions and tachyarrhythmias. So, what are the investigations? We can check for the plasma electrolytes, bicarbonates, urine potassium with plasma calcium and magnesium. The plasma renin activity will be low in the patients with primary hyperaldosteronism, and measurement of the urine chloride concentration A with low chloride, urine chloride less than 30 millimole per liter, it is characteristic of vomiting. So if there is chloride, urine chloride that is less than 30 millimole per liter, then it will suggest greater amount of vomiting. And if the urine chloride is greater than 40 millimole per liter, it will suggest a diuretic therapy. In the ECG, we are going to see ST segment depression. So there will be ST segment depression that will be seen because of the lower level of the potassium, and appearance of U wave will be a characteristic. Now, what are the effects of hypokalemia? So severe hypokalemia will produce premature ventricular and atrial contractions. So there will be arrhythmias, tachyarrhythmias because of the premature ventricular and atrial contractions. Now, how to manage a case of hypokalemia? So if there is decreased potassium level in the blood, how to manage it? So first of all, we have to identify the cause and we have to treat that particular cause. Next is we can give the oral potassium. The oral potassium that can be given is from 20 to 100 milliequivalent per day. It can be given via the fruit juices, the coconut water, or IV. The care in the patient with impaired renal functions to avoid hypokalemia. So we can care the patients with the impaired renal function. So if the impaired renal function is there, then we can treat accordingly. And potassium sparing diuretics can be given, such as spironolactone. These will reduce the fluid content of the body without affecting the potassium ions. And if there is magnesium depletion that is also present, then replacement of the magnesium may also be necessary to allow correction of the hypokalemia. So this was all about hypokalemia. Next, we come to the hyperkalemia. Hyperkalemia, that is the increased concentration of potassium in the blood greater than 7 millimole per liter. So hyperkalemia can be dangerous. Hypokalemia was not that much dangerous, but hyperkalemia can be dangerous because it can produce cardiac arrest. Cardiac arrest that is caused by slowing of the action potential. So it is causing slowing of the action potential with conduction in the presence of potassium level above 7 millimole per liter. So hyperkalemia, when the potassium level is greater than 7 millimole per liter, and it can produce cardiac arrest. So it is very dangerous condition. Now, what are the causes of hyperkalemia? Hyperkalemia may be caused because of the inadequate excretion when it is not excreted properly, due to the shift of potassium from the tissues, and due to excessive intake. So if there is inadequate excretion, if there is excessive intake, or if there is shift of the potassium from the tissues to the intracellular fluid. So inadequate excretion is seen in the cases of renal failure. There can be acute or chronic tubular disorders with adrenal insufficiency. There can be renal Addison's disease with hypoaldosteronism. Potassium sparing diuretics can be given. Shift of potassium from the tissues, that is seen in case of acidosis, that can be metabolic or respiratory. There can be tissue injury with muscle damage, hemolysis, or internal bleeding. There can be hyperosmolarity with insulin deficiency, hyperkalemic period paralysis, or there can be excessive intake with impaired renal function. So inadequate excretion is seen in renal failure, acute or chronic tubular disorders, adrenal insufficiency, Addison's disease, hypoaldosteronism, and potassium sparing diuretics. Shift from potassium to tissues is seen in case of acidosis, that can be metabolic or respiratory. Tissue injury, that includes muscle damage, hemolysis, internal bleeding. It can be seen with hyperosmolarity, insulin deficiency, hyperkalemia, period paralysis, or excessive intake with the improper renal function. Now, what are the clinical features with hyperkalemia? Hyperkalemia patient presents with progressive muscle weakness. So there will be progressive muscle weakness, but sometimes there can be no symptoms till the cardiac arrest is seen. So it is very dangerous because without the symptoms, cardiac arrest can take place. And there will be generalized weakness of the skeletal muscles. So this is more severe because we don't get much symptoms in case of hyperkalemia. Now, what are the various investigations that could be done? Investigations includes the serum potassium level that is greater than 5 milliequivalent per liter. We can also check for the typical ECG changes that shows a peaking of the T wave. So serum potassium level, it is greater than 10 milliequivalent per liter, greater than 5 milliequivalent per liter, and ECG changes shows peaking of the T wave. There is widening of the QRS complex because of the increased contraction time of the ventricles. There will be prolonged PR interval. So widening of the QRS, prolonged PR interval, and disappearance of the P wave can be seen. There will be nodal and ventricular arrhythmias that could be seen. The QRS complex merges with the T wave in the sine wave pattern with ventricular asystole or fibrillation. So the QRS complex merges with the T wave and in the sine wave or the ventricular asystole or fibrillation. So we have serum potassium level greater than 5 milliequivalent per liter, typical ECG changes showing peaking of the T wave, widening of the QRS complex, disappearance of the P wave, nodal or ventricular arrhythmias, and QRS complex merging with the T wave. Now, how to manage a case of hyperkalemia? Because this is a life-threatening condition, this produces a cardiac arrest, so it has to be managed properly. The treatment depends on the severity and the rate of development of the symptoms. So how severe is the disease condition? How the symptoms are appearing? On this, the treatment protocol depends. In absence of the neuromuscular symptoms or ECG changes, reduction of potassium intake and correction of the underlying abnormality. So if there are no changes in the ECG, if there are no muscular symptoms, if there are no any other serious complication, then just reduction of the potassium intake and correction of the underlying abnormality can be done. In the acute or severe hyperkalemia, when the potassium level is greater than 6.5 to 7 millimole per liter, most urgent measures are to be taken. If the potassium level is more, then most urgent measures have to be taken. And to stabilize the cell membrane potential, infusion of the calcium gluconate to stabilize the conductive tissue disorder. So immediately we have to stabilize the cell membrane potential by infusion of the calcium gluconate in order to stabilize the conductive tissue membrane. To shift the potassium into the cells, we have to give IV glucose and insulin, and intravenous sodium bicarbonate has to be given. And to remove the excess of potassium from the body, we have to give intravenous furosemide and normal saline. Ion exchange resin, which include resonium orally or rectally, and also we can go for dialysis. So management consists, if the patient is not showing any symptoms, then just reduction of the potassium intake and correction of the underlying abnormality. If there is increased level of potassium in the blood, then we have to stabilize the membrane potential by giving calcium gluconate. To shift the potassium into the cell, we have to give IV glucose and insulin. And in order to remove the excess of potassium from the body, we have to give IV furosemide or normal saline. And also ion exchange resin that include resonium that can be given orally and rectally, and then dialysis can be done. So this is all about the potassium disorders of the potassium metabolism. I believe you must have understood this session. Now it's your homework to go through the book and to check for this particular topic and prepare your notes. I've also uploaded this PPT on the portal, so you can also go and refer that particular PPT. So this session is powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope this session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.